كانت كويسه والتشيك ان كان كويس، والدكتور نبيل المنير الحقيقه اكد لي على دي، ودي حاجه كويسه يعني. معلش احنا عاوزين نستيك تو تايم، فهنبدا دلوقتي اول سيشن. احنا عندنا النهارده 2 سيشن، الاوبننج سيرمون بكره الساعه 11 وربع، وبعدين هنبدا من الساعه 9. فهنبدا دلوقتي. بالنسبه للفوتنج احنا اسفين بس مش موجود الديفايس، فهنبقى بالطريقه البلد العاديه برفع الايد في الاول. ماشي يا دكتور ايمن؟ فمعلش نبدا بقى.
الزرار تحت يا دكتور ايمن، الزرار تحت يا دكتور. بس كده تمام.
بسم الله الرحمن الرحيم. كل سنة وانتم طيبين. وطبعا احنا كلنا في منتهى السعادة ان احنا نبتدي المؤتمر السنوي ال14 لجمعية مصر لجراحة وعلوم الأوعية الدموية، وبالاشتراك مع الفاسكولار كلاب اوف ايجيبت. وان شاء الله اول جلساتنا هتكون تايتل فينس سيرجري، وزي ما الدكتور ناصر قال لنا ان احنا هيبقى اول جزء في الجلسه الاولى هيبقى عباره عن ديبيت. الديبيت الموضوع بتاعه هيبقى على interventional management versus drug therapy for iliofemoral DVT. هنبتدي مع بعض وهنسأل السؤال التقليدي بتاعنا في أول الديبيت، وهنستأذنكم مين ال going with interventional therapy أو interventional management for iliofemoral DVT. مؤقتا هنعملها with raising hands. مين الموافق على interventional therapy؟ طيب يعني طيب اوكي. مين اللي موافق على
سهم يمين فورورد وشمال باكورد؟
وده ليزر؟
لا مفيش ليزر على الليد، الليزر هيبقى الجهاز ده يا دكتور.
لا هو يعني هو احنا هنقولها عشان تبقى اوضح. مين مع الانتي كواجوليشن ومين مع الانترفنشنال from the start from day one. مين موافق على الانترفنشنال مانجمنت لإليوفيمورال DVT from day one in acute iliofemoral DVT؟ طيب مين اللي موافق على الانتي كواجوليشن؟ يعني تقريبا تعادل. تقريبا تعادل. لما نشوف بقى هنبتدي مع الاستاذ الدكتور هشام شرف. هيكلمنا طبعا الدكتور هشام استاذ في كليه طب جامعه المنصوره، هيكلمنا هو with the motion of interventional therapy of acute iliofemoral DVT.
بسم الله الرحمن الرحيم. أحب في البداية أن أشكر زملائي الأعزاء الدكتور ناصر السعيد والدكتور طارق رضوان وجامعة الأزهر بالمشاركة في هذا الأوتستاندينج إيفنت اللي بيجمعنا دايما على الخير والحب بين عائلة أو أسرة جراحة الأوعية الدموية المصرية. وده الحقيقة حاجة كويسة قوي، لأن كل الناس دائما يعني ايه بتربطنا على هذه الرابطه والحب المتبادل بيننا ان شاء الله. الحقيقه الموضوع طبعا تشالنجينج. الدي في تي من الموضوعات اللي هي ستيل تشالنجينج تيل ناو، عشان كده يعني ما زال الاراء فيها مختلفه. فبس في الانترودكشن why iliofemoral DVT. As we all know that major DVT representing a major public health, representing a significant clinical and economic disease burden on health system. In UK alone, approximately 59,000 new cases of DVT arise per year, and the venous thromboembolism account for more deaths than the composite mortality of breast cancer, AIDS, and road traffic accident. So it is a major problem even in the developed country. Up to 21% of DVT may lead to pulmonary embolism. It is a potentially life-threatening complication. Furthermore, DVT may cause severe morbidity in short term from phlegmasia cerebrodolens and venous gangrene, also long term from chronic venous hypertension and post-thrombotic syndrome. Up to 10% of patients with DVT develop a very nauseous venous ulcer. This conventional treatment of acute DVT is immediate anticoagulation. This is the conventional method with low molecular weight heparin or unfractionated heparin, followed by a period of 3 to 6 months of oral anticoagulation with VKA or new oral anticoagulant. This aims to prevent the thrombus propagation and to reduce the risk of pulmonary embolism and the recurrence of DVT. But early lysis or thrombectomy has been proposed an attractive option in the treatment of DVT, as this might prevent venous obstruction, valve incompetence, venous hypertension from developing. This in turn might reduce the incidence and the severity of BTS and reduce the incidence of subsequent venous ulcer. CDT or catheter-directed thrombolysis has been recommended as an effective therapy for DVT because it can reduce the thrombus load, relieve DVT symptoms, and maintain the venous valve function and reduce the recurrence of DVT. So nowadays, the endovascular intervention management for acute iliofemoral DVT may weight the or overcoming the weight of the conservative management, as I mentioned before. When I search in using PubMed, MBUS, and Web Science, Cochrane Library, I search about from 1980 to 2017. This search included the following: CDT, standard anticoagulation, iliofemoral lower extremity DVT, comparative study, or RCT, or cohort study, or respective and prospective study. The results: the anticoagulation alone was not associated with dissolving the venous thrombus, leading to chronic venous dysfunction in patients with DVT. Systemic thrombolytic therapy was also abandoned because of high risk of bleeding event and inefficacy in resolving the thrombus. So the catheter-directed thrombolysis has been developed for dissolving thrombus in patients with acute lower extremity DVT compared with systemic thrombolytic or anticoagulation alone. CDT plus anticoagulation therapy was demonstrated as more effective for dissolving the venous thrombus. The trials, the CAVINT trial, follow up to 24 months, revealing the rapidity eliminated iliofemoral thrombus, could improve the iliofemoral vein flow because CDT therapy was used in acute phase, and the meta-analysis revealed that CDT can increase the percentage patency of the iliofemoral vein. Furthermore, 5 studies, 1 randomized controlled and 4 non-randomized controlled studies revealed that CDT was effective in reducing the morbidity rate of BTS. However, the 2-year results from ATTRACT study, the only study demonstrated that CDT could not prevent the BTS. I suggest that the ATTRACT study meaning the minimal BTS, not severe BTS. 2 studies and the ATTRACT study stratified according to the prevention of severity versus mild BTS. However, 3 studies didn't have uniform standard definition of grade of the BTS. Meta-analysis indicated that CDT could reduce the severity of BTS and the patient quality of life, and the early DVT symptoms may be improved by CDT therapy. The catheter-directed thrombolysis plus anticoagulation could provide safe and effective method for removing the venous thrombosis in patients with acute iliofemoral DVT in this acute phase. The ACCP guidelines showing the benefit of CDT were assessed using three measures tried: Cavity trial, Attract trial, and the CAVA trial. The Cavity trial is a multicentric trial with RCT that included patients with acute DVT in iliac and the common femoral or upper femoral vein. And in this trial data suggested that CDT improving the clinical relevant long-term outcome in iliofemoral DVT. The Attract study was multicentric randomized assessor blinded clinical trial in the United States using pharmacomechanical caster dielectric thrombolysis اللي هو BCDT, whereas the Cavity study using conventional perfusion casters were used. In the Dutch CAVA trial, the ongoing RCT and CDT therapy comparing anticoagulation therapy alone, the data from CAVA trial may give more clinical evidence of CDT versus anticoagulation therapy. And the risk-benefit ratio for patients with DVT must be considered before any therapeutic protocol. This meta-analysis demonstrated that CDT improving the patency of iliofemoral segment and the severity of BTS after that. Guidelines of ACCB suggesting that pharmacomechanical thrombolysis provide greatest benefit in younger and functional active patients with extensive and proximal thrombus in the IVC or iliofemoral segment who have an acute presentation of DVT less than 14 days or with phlegmasia cerebrolidolens.
Dr. Hisham, 2 minutes left.
Okay. The anatomical site of DVT is important, and the DVT behaves differently at different sites, and also the thrombus age appeared to correlate negatively with the success of lysis. The Cavity study demonstrated a significant increase in patency at 6 months follow-up after CDT of the iliofemoral DVT in patients treated up to 21 days after the onset of the symptoms. The Attract trial, which report on outcome of the combined pharmacomechanical thrombolysis and CDT in the United States, has used 14 days as the cutoff for recruitment of patients. The common left iliac vein compression, May Turner syndrome, is also one of the challenging cases needing the thrombolysis and the stenting. So you can using wall stent or nitinol stent, and the operator of the stent in the iliac vein is decision in the setting of the DVT, and the primary patency rate of this stent is about 79% at 72 months follow-up. Pharmacomechanical devices are categorized as rotational, rheolytic, ultrasound enhanced. This is the most important devices present nowadays. And the rationale of using of these devices, like the trellised, angiojet, and the echoes, early procedural outcome were encouraging, and the series reviews reported technical success of about 28 to 100%, demonstrating the visibility of BTM. This is the different types of the devices. So, in my conclusion, one conclusion بس.
مش هيفتح السيستم. قولها oral بقى.
So, in my conclusion that when we using caster dielectric therapy plus or minus pharmacomechanical thrombolysis, the patency of the venous system in the iliofemoral segment in acute phase, as I mentioned, for 14 or 21 days onset, makes significant improvement in the result as the patency and the valve competence and the subsequent BTS. So I voting for using CDT and the interventional lytic therapy for patients with acute iliofemoral DVT. Thank you very much.
Thank you, Professor Hisham, for this very nice illustration. Now I call Professor Ayman Samir from Zagazig University. He's going to defend the direct therapy for acute iliofemoral DVT.